Oh, yeah. Hello, dear students. Welcome back. Sorry for that episode of technical glitch. Now, in this session, we will start with ENT. Very first question was about the location of nasopharyngeal carcinoma, for which image was given, and then the student was supposed to identify the usual or the commonest location for nasopharyngeal carcinoma. Now, we know that nasopharyngeal carcinoma, it occurs most commonly in fossa of, right? It occurs most commonly in fossa of Rosenmuller, and this is the location of. So the white arrow is actually representing the most common location of fossa of. This is the most common location of fossa of Rosenmuller. Now we can just take the other landmarks as well, which are being shown in this image. Now, if you look here, you can see an opening, and this is the eustachian opening of the eustachian tube, which opens into the nasopharynx, right? So this is thing of tube, which is also known as nasopharynx, which connects the middle ear with nasopharynx. Here, so it connects the middle ear with the nasopharynx. Normally, usually it is closed and opens only when there is coughing, yawning. So increases opens up to opens up whenever there is increase in the oral pressure. Visualize that is the tube, or also known as the pharyngotympanic tube. This is pharyngotympanic tube. Clear? So this is the location of eustachian tube, and posterior to this is the fossa of Rosenmuller, right? So this is the fossa of Rosenmuller. Now here you can also see inferior turbinate. So this one is inferior turbinate. Then you can also see the middle turbinate. So this is middle turbinate, and below middle turbinate you can see bulla ethmoidalis. This is bulla ethmoidalis, right? Here you can see the sphenoid sinus. Okay, so these are few landmarks which you can see on the lateral wall of nose. And lower down, this is hard palate. And why we call it hard? Because it is made up of bone. Posterior to hard palate, this is the soft palate, and soft palate is known as soft because it is made up of muscles. So this is lateral wall of nose, and of course the fossa of Rosenmuller is the most common site of nasopharyngeal carcinoma. So this is the fossa of Rosenmuller, this area, right? And this is the eustachian tube opening here. Now, there was another question about the symptoms of Gradenigo's syndrome. Now, Gradenigo syndrome is a complication of chronic suppurative otitis media where there is apex petrositis. So it presents with ear discharge, retroorbital pain, and diplopia. So ear discharge, retroorbital pain, and diplopia. I think all of you must be knowing what is diplopia. This is double vision. Okay, so there is ear discharge, that is because of CSM. There is diplopia, the person will see double vision, and then there is retroorbital pain. retroorbital pain. This is because of involvement of trigeminal nerve, right? So cranial nerve 5 involvement. So this is Gradenigo syndrome, which is a complication of chronic subacute media. So please remember the triad of Gradenigo syndrome: ear discharge, diplopia, and retroorbital. Now, then another question was from again a very important segment, and that is the lateral wall of the nose. And it was asked like where anterior-ethmoidal sinus opens. Now, anterior-ethmoidal sinus opens into the middle. And we can take the diagram of the lateral wall of nose, and here you have to remember superior meatus, right? Then middle meatus and inferior meatus. Okay, so inferior meatus. Clear? And apart from this, you can also write supreme meatus. Okay, these are the 4 meaters, and students should know what sinus or what structures open into these. The easiest of all is the inferior meatus, where there is opening of the nasolacrimal duct. There is the opening of nasolacrimal duct. Here, supreme meatus, there is opening of sphenoid sinus. Okay. In superior meatus, there is opening of the posterior ethmoidal sinus. And now the remaining all, frontal, anterior-ethmoidal, maxillary, they all open into middle meatus, right? So anterior ethmoidal, then frontal and maxillary. Okay, so all these sinus, they open into the middle meatus. So I think student, they have to be very perfect with these all. So this is the opening of sphenoid sinus. Okay, so this is the supreme meatus, opening of sphenoid sinus. Then this is the posterior ethmoid, which is opening into the superior meatus. Then this is the nasolacrimal duct into the inferior meatus. Then in the middle meatus, we have all frontal, maxillary, anterior, and middle ethmoidal sinus, right? This is very important. Then there was a new question, and it was about the staging system, which is used for juvenile nasopharyngeal angiofibroma. Now, usually till date, we have questions usually about diagnosis or about investigations or that Holman-Miller sign and all. But this time they have asked about the staging, and this is altogether a new question and slightly tough on the part of student, because as a faculty, we don't usually teach this. So this is Redkowski staging system, which is used for, so Redkowski classification for juvenile nasopharyngeal angiofibroma. Just remember the name. Now, coming to next question, what is the initial management in a case of CSF? Now, this we have already discussed when CSF rhinorrhea, while we are discussing the fracture of fibriform plate of ethmoid, right? So the CSF from the anterior cranial fossa leaks into the nasal cavity. Okay? So the CSF leaks out, and this is CSF rhinorrhea. Now, what we need to do here, we need to put the patient on bed rest, elevate the head, and tell the patient, don't do any exertion. Don't do any straining activity like coughing, constipation. All those things should be avoided. So that's why we give full softness. Right? So we just want to avoid any sort of exertion by the patient. So that is the usual approach early initial phase of CSF rhinorrhea. So bed rest, then elevation of the head, stool softness, right? No straining should be done. Now, next question was about the hearing screening in a newborn. So, in a newborn, hearing screening is done by autoacoustic emissions, right? So, this is very important. So, it is a kind of screening test and especially done for newborn. So, autoacoustic emission. Then there was one term that is laryngemus stridulus, that is what like laryngospasm, especially seen in hypocalcemic states, which is because of vitamin D deficiency, right? So laryngitis stridulus. Now, in a child, if there is adenoid hypertrophy, which is causing nasal obstruction and at times is causing sleep apnea, what will you do? So if the adenoids are enlarged, they will block the nasopharyngeal air flow, and therefore we need to remove the adenoid. So adenoid has to be done. So for adenoid hypertrophy. Now this is very important to remove the adenoid at a earlier period in pediatric age group, because if this entity is not addressed, then what will happen? Patient may later have serous sinusitis, right? There may be high arch palate, and there may be like I won't be used for long, so they might collapse. You can say like that. So if this happens, then we have to go for the option B, right? So here, adenoidectomy plus here, problem is only with adenoid, so we will go with adenoidectomy. If it is associated with serous otitis media, then only we will do laryngotomy with grommet tube insertion, addressing the serous otitis media as well. But in the question, there is no mention of serous otitis media. Simply, it is adenoid hypertrophy which is obstructing the air pathway. So we will do adenoidectomy, right? So A is better answer here. Now, a patient with trauma had hearing loss, and when HCRT is done, high resolution CT scan, which structure will not be visualized? Now, on CT scan, we can see cochlea, we can see vestibule, we can see semicircular canals, but we cannot see or we cannot mark out organ of cortex, right? So if you look, this is the CT scan, and here we can clearly see the cochlea, we can see the vestibule, and we can see the semicircular canals as well. All semicircular canals. But organ of cortex, which is the which is the organ for hearing, it is not visualized on CT scan, right? So organ of cortex will not be visualized. Now this finishes the ENT part. Now we'll go to the orthopedic section, and here one question was about a Codman's triangle, and I think pretty easy for all of you to answer it as osteosarcoma. Okay. So what actually we do now? This is the periosteum. This is the periosteum. So the tumor lifts the periosteum. This is the cortex. Okay. This is cortex. So what we can see here, we can see a triangular area like this. So this is That is of osteosarcoma. Then patient had a growth behind the talus. Now what condition is this? So this was the X-ray given, and we can see there is, now this is the head of talus, then this is the body of talus, and behind the talus we can see a bony growth, something like this, right? So this is actually exostosis, which is also known as osteochondroma. Previously we have a question from this segment many times, but always it was like a lower end of femur which was given in the X-ray, but this time they chose to take X-ray of foot or ankle in the exostosis, which is originating from talus, right? This is osteochondroma exostosis. And just a few words about exostosis or osteochondroma. It is the most common benign bony tumor, right? It is the most common benign bony tumor. Now, if add the word primary here, so this is osteochondroma. If I add the word primary here, the answer will become osteoid osteoma. So please remember this. Most common benign primary bony tumor is osteoid osteoma. If I remove the word primary from here, then it is osteochondroma. Why so? Because it has got a cartilaginous cap, right? So there is a cartilaginous cap as well, right? And therefore you will find the word chondro here. Chondro is actually cartilage. It has a cartilaginous component as well, and since that cartilage is not shown on X-ray, so when we take the X-ray, we presume that okay, the tumor is only of this much size. But when we operate, we find the size of the tumor to be actually much more larger than what is being shown on the X-ray, and the reason is that because it is covered by cartilage. So suppose if on the X-ray the size is this much, okay, but when you will operate, you will see that the tumor is somewhat this. This is because this all is the cartilaginous cap. And this cartilaginous cap is not visualized on X-ray, and therefore on X-ray it looks small on bony component, right? And therefore this is known as osteochondroma. Derivation of this term. Now this cartilaginous cap is very important in terms of prognosis, because if it is more than 2 centimeter, of course on MRI it suggests malignant conversion, because what we discussed, it is a benign entity. It can become malignant, and how we can check that? One thing is, like, if the size of this cartilaginous cap is more than 2 centimeter on MRI, and also if swelling increases in size even after puberty, because this tumor usually grows till there is activity at the growth plate. It won't increase in size after that, but if it is still going beyond that period, you can say that now it has changed from benign to. These are two factors which help us checking whether and still or it is gone malignant. So this is osteochondroma, and again new image, so might be little confusing for the student. So this is, now there was a question about the Salter and Harris classification. So X-ray was given and it was asked, like, it was which type as per Salter and Harris classification. So again, this is a conceptual question. If you know the concept properly, then you have to apply this concept or the concept over the X-ray, So it is actually a two-stage question and a slightly difficult from exam point of view, because at times it becomes really difficult. So if you, so you can say this is epiphysis, and this is the metaphysis, okay, the broken part, and this is the meaning. And then this is all physis. So this is all physis, right? Or physis, or what you call growth plate. This is metaphysis. Now, what you can see here, that there is a fracture, and there is a fragment of the metaphysis which is still attached to the growth plate and epiphysis. Right? So you can have this kind of picture, and this is actually Salter-Harris type 2. In Salter-Harris type 2, what we see you can see that a chunk of metaphysis is still attached to the epiphysis along with the growth plate. So such kind of injury is known as Salter-Harris type 2, where there is a fracture through the growth plate, with a triangular portion of the metaphysis still attached, and this is known as the Thurston-Holland sign. This piece of the metaphysis is known as Thurston-Holland sign. Okay, so this is type 2, and this is a classical X-ray depicting the type 2, right? This is Salter-Harris type 2 classification. Now, then there was an X-ray of a person who has fall on outstretched hand as push injury, right? So fall on outstretched hand, and then X-ray was given. Here, if we look at the X-ray, this is the first here we can see bony fragment, right? So this is the fracture line here. This is the fracture line. Now, this fracture is intra-articular. I say intra-articular because intra is, that is joint. So it is involving the base of first metacarpal. It articulates with triquetrum, right? So this is trapezium, sorry, the trapezium, and this is first metacarpal, and this is the articular surface, right? So if there is any injury, this is the articular surface. So if there is any injury which is disturbing this articular congruity, such a fracture is known as intra-articular fracture, and this is actually the Bennett's fracture, right? So this is Bennett's fracture, and since it is involving the articular surface, and the surgical principle is always do open reduction internal fixation for intra-articular fractures, because you have to restore the articular congruity of the bone, otherwise that will result in degradation of the hyaline cartilage, and that the patient can go into secondary osteoarthritis, right? So this is Bennett's fracture, and intra-articular fractures are always to be managed by open reduction internal fixation, unless option is like if there is no displacement, then only you can go for conservative. Now here you can see that the main uh, the first metacarpal, right? And then at the base, you can see the small chunk. This is the small chunk, and there is displacement, and usually the displacement in any fracture is because of muscle pull. Yeah, so different muscles, they pull the fragment towards their side of their action, so that was caused displacement of the fragments. So here we can see the muscle which is abducting the fragment is abductor pollicis longus muscle, right? So that's how this fragment gets displaced, and on the upper side there is adductor pollicis which also pulls the fragment and therefore displacing the fracture, right? So that's why this creates a necessity for doing open detection internal fixation. So anyway, this is Bennett's fracture, and you can see the fracture line is linear intraarticular. Yeah, and intraarticular. There is one variant of this where, suppose if the fracture line is here, the fracture line is this. Sometimes the fracture line also extends outward, and then the fracture configuration looks like Y or T. So we say that there is fracture with intraarticular fracture with comminution. So it is known as intraarticular fracture. Towards base of first metacarpal plus comminution. Then it is known as Rolando's fracture. Clear? Both involves the base of first metacarpal. It is just they differ in the their configuration. So linear in Bennett's and Y or T shaped in Rolando's. Then there was one more question in which a patient was hit by a car from side while he was crossing the road, and there was fracture of both tibia and fibula at the primary impact site. Now this is, I think, easy to see because it is the bumper portion of the car which hits the lateral side of the knee, and therefore there is fracture of the fibula head and lateral tibial condyle, so that is known as the bumper fracture. So just to give you an idea, like this is how the bumper of the car hits the lateral part of the knee joint, right? So this is the bumper which is hitting the lateral part of the knee joint, and therefore what we will see in fracture, we will see there is fracture of lateral tibial condyle, or sometimes you call it tibial plateau fracture. Of course, there will be associated fracture of the fibula as well, right? So this is the bumper fracture. The hit is from the side. Actually, the bumper part of the car hits the fracture. So this is, since it is because of bumper of the car, so it is bumper fracture, and it is involving the lateral part of the tibia. So lateral tibial plateau fracture. Then I think this is a very basic question. No need to discuss anything. Rickets, vitamin D. Okay, and in rickets we can have any sort of deformity over the knees. Can be genu valgum. Yeah, genu. And there can be genu varum, right? So like this. Then there will be wind swept deformity where there is genu varum in one. So this is genu varum. Genu varum in one, and there is genu valgum in another. Clear? So it looks as if the wind has swept both the knees in one direction. So this is known as wind swept deformity. Then there can be saber tibia or genu recurvatum as well. Now there was a case where there was an accident around the wrist, and Many months later, the patient developed hypothenar atrophy. Now, the hypothenar area is below the little finger. Here, this area is supplied by ulnar nerve. So, all the muscles of the hypothenar eminence, or the four muscles of the hypothenar eminence, are supplied by ulnar nerve. Right? And although in this question there could have many more descriptions like wasting of, might be sensory loss over the medial 1.5 volar side of palm. There could have been much more findings suggestive of ulnar nerve injury. Anyway, the hypertrophy, the atrophy of hypothenar muscles is itself very sensitive of ulnar nerve injury. And here, if there is an injury at wrist, there can be compression of the nerves in the Guyon's canal, right? So this is pisiform bone here. This is pisiform, and then there is hook of. So then there is a retinoculum which covers these two. So it converts area into a tunnel through which there is passage of ulnar nerve. So sometimes there might be compression neuropathy of the ulnar nerve in the Guyon's canal, and right, this can also lead to ulnar nerve neuropathy. Patient will have all the specific features like medial 1.5 volar side sensory loss, hypothenar atrophy, and wasting over the in between the metacarpals. Then there was one question about tuberculosis of hip, and the patient was having true shortening. Now, which stage is TB hip with true shortening? Now, here to understand this, to answer this question, you have to understand the concept. There are three stages: stage of synovitis, early arthritis, and advanced arthritis. Right. So, what happens in stage 2, which is actually the stage of synovitis? Stage 2 is early arthritis, and stage 3 is advanced arthritis. Right. So, what happens in stage of synovitis? There is inflammation of synovium, as a result of which there is increased production of synovial fluid. Now, synovial fluid is contained within the joint capsule, right? So, to accommodate this process of synovial fluid, the hip joint will go into a position of Faber. Flexion, abduction, external rotation. Because this is the position in which it can, its capacity is maximum to accommodate to produce synovial fluid. Now, what will happen? The moment patient assumes this position, this is abduction, right? Then external rotation, and of course, flexion. So this is Faber. Now, in Faber, what looks from a distance is that this lower limb is appearing lengthier, right, as compared to this. So there is lengthening. Number one, there is lengthening. But when you measure the actual length of both the lower limbs, it is same on both sides. So it means this lengthening is apparent lengthening. Apparent lengthening means it is looking from a distance as if the limb is lengthier than the other side, but on exact measurements, they both are of the same length, and therefore there is no shortening as such. It is just, there is no change in length as such. It is just, it's looking little length, right? So this is the cause of apparent lengthening. This is important. Now, what happens if the condition is not addressed at this stage? Now, the bacterium will start involving the joint surface, that is arthritis. As soon as there is arthritis, there is inflammation of the surrounding muscles, right? So there is inflammation of the surrounding muscles, and we know that there are few groups of muscles which are there. One is flexors, extensors. Then there are abductors and adductors, right? And there are external rotators and internal rotators. So all these muscles will be inflamed, but muscles which are powerful, they will overact and they will pull the limb in the direction of their action. So these powerful muscles are flexors, adductors. These are adductors and internal rotators. So since these are powerful muscles, so powerful muscles will pull the limb in their direction, right? So flexors, adductors and internal rotators are powerful, so the attitude will become fader, right? So the attitude will become fader. Now, as soon as there is fader, flexion, adduction, internal rotation. So as soon as there is fader, it will look as if this length is shorter than the other limb. So there is apparent, there is shortening, and when you measure both the lower limbs, the length will be same. So you will use the word apparent. Right? So there is apparent shortening. From a distance, it looks as if the limb is shorter, but in reality, the length is almost same as that of the. So there is no shortening as such. It looks from a distance, so it is apparent shortening. This causes apparent. Okay. Now, if the condition is still not addressed, there will be increased damage to the bony, especially the head of femur. So there is bony damage, and now the attitude will remain same. So there is fader. This fader will continue in the third stage as well. So again, there is flexion, adduction, internal rotation, right? But what will happen here? There is, of course, there will be shortening. But if you measure here, you will see that the affected limb is really short as compared to the opposite limb, right? So the limb is really short, and therefore we will call it true shortening, because there is actual damage to the bone, so that the overall length of the bone has reduced. So it is known as true shortening. So in advanced arthritis, when there is actual damage to the bone, the actual length of the bone will be reduced, and when you measure the actual length, it will be shorter than the other normal limb. It is true shortening, right? So this is what is the concept of stages of tibia of hip. Right? The moment you get the word true shortening, it means it is advanced arthritis where there is already damage to bone, and once the bone is damaged, it will really little short in length as compared to the other side. So the answer would be stage, right? In a stage 1 or 2, length is same, it's just the perception is different. It may look lengthier in stage 1, it may look shorter in stage 2, but actual length is same, right? So this is the concept of TV hip. And again, this is a very important segment and has been asked many number of times. Please make sure that you are good with this much. So that's the end of this session, and I have prepared only this much matter. Ophthalmology and some short subjects are still pending. So for the time being, this is enough from my side for this second session. I thank all of you for joining me and giving me this valuable opportunity to share my knowledge with all of you. So see you soon. Bye bye.